apparently on its way. But I wanted to do some sort of drawer-keeping activities. In your packets, there's a, this is the standard evaluation sheet, and please fill out the evaluation. Your CME credits are also in the packet already, but the medical staff office needs to get a fair sampling of these to make it a verifiable activity. And going on the hope that in a second Dr. Hooshmand will be here, I'll tell you a little bit about him and how he comes to us. Dr. Hooshmand recently published the first monograph, the semi-textbook on Reflex Sympathetic Dystrophy. And in relationship to one of the patients that we were seeing in the pain clinic that was very difficult, I called him in consultation hoping that he would be gracious enough to talk to me and give me some advice. And in the process of doing that, he volunteered to come at his own expense here to talk, and that's what the result of this is. His training is that he is a neurosurgeon initially by training at the Mayo Clinic. After his neurosurgery training, he practiced neurosurgery for some time and then did a neurology residency at the Medical College of Virginia. He then apparently stayed on the staff there and became a professor at the Medical College of Virginia. He received the Medical Student Teaching Award 3 consecutive years. Being basically a neurologist, neurosurgeon, I'm not familiar with all his accomplishments, but they're multiple. He's published over a combination of articles, abstracts, that sort of thing, 70 or 80 plus articles. He's had a number of firsts in medicine. He was the first person to recommend a very high-dose penicillin in the treatment of neurosyphilis. He did the initial work with Decadron, increased intracranial pressure, and described the mechanism of action. He was the first to describe the use of clonopin in the treatment of seizure disorders. He is published extensively on EEG and topographical things I don't know anything about, topographical brain mapping, that sort of thing. He has also written about electrical injuries and has over 400 or 500 patients who he's seen and treated with chronic pain after an electrical injury. He practices now in Vero Beach, Florida, and is in private practice there. He sees 3 new RSD patients a day currently. 10% of his practice is in-county, 40% is from the state of Florida, and 50% or more is from out of state. He sees patients from Canada and elsewhere. So, you can stop the video camera.
There's a lot of emergency rooms that don't believe it exists, and that is called RSD. And I'm not blaming any doctor, it's mainly because it's such a complex subject. I need help here. Oh, it's working now, I'm sorry. Thank you, I got it. It's such a complex subject that it's difficult to understand, it is difficult to teach, and it causes symptoms and signs that are so complex that baffles everybody. The first thing I want us to understand that there are 2 different types of pains. One is called somatic pain, and the other is called sympathetic pain. The difference between the somatic and sympathetic pain is that in somatic pain, somatic pain, the pain ends up in the cortex of the brain, in cerebral hemispheres, and you may remember from your anatomy that that the pain ends up in what they call a homunculus, an ugly-looking guy with a big tongue sticking out. It's just in the parietal cortex. And so if I, for example, have a mosquito bite right over the base of when I'm fishing, and at the base of my index finger, I get a mosquito bite, it hurts. I know exactly it's the right index finger, it's at the base of it, just the first metacarpal. I don't even need to look. My brain tells me exact location of it. I scratch it and just rub it a little. It's gone, no harm done. Everybody is happy, especially if I catch the big fish right after that, will go way quicker. If this was because of scratching during the sex, when you get to climax, the endorphins completely wipe it out, and everybody's happy. This is the somatic pain. The sympathetic pain, I have drawn this, my daughter drew it, and then we put it through a computer. We have put the green and blue color as the somatic, and the red color as the sympathetic. The sympathetic pain is just the opposite. It's not you don't need to have cerebral hemisphere to have this kind of pain. You can be a worm, you have sympathetic pain. You put a worm in a fish tank, heat up one side of it, it gets too hot, worm wiggles, goes to the other side. Cool off the other side of it, worm comes right in the middle, exactly in the middle, and stays there. It causes a temperature type of pain that allows the worm to understand where to go to prevent further damage to its internal environment. It is primitive. It's present in all the animals, even though they don't have cortex. And the more primitive it is, the less cortex you have, the less inhibition you have, and the less emotional connotation it has. Because you can control and gauge our emotional connotation by inhibition of the frontal lobe. The difference between a human being versus a shark or dog is that we have a big bulging forehead. We are not the top species in animals in the world. We are not the smartest. We are probably the most harmful animal in the world. But the smartest and the most advanced one is a killer whale. We call it killer because when they kill us, they come back and kill. When we kill them, they come and kill us. They say, oh my, that guy's got nerve to come back and kill us. But they have 15% more nerve cells and 15% more cells in the frontal lobe. So the frontal lobe gauges and decides what kind of emotional response you should have in this situation. Well, that is more for the conscious one, the somatic. When it comes to the subconscious one, you don't need frontal lobe, and your emotion is totally under control. So it causes. Now, how does this happen? Let me show you an example. You can have a severe gallbladder attack, this real bad gallbladder problem, and you get bad a rupture of the gallbladder, peritonitis. You get the operation. They pour the antibodies in there. For several days you're hurting. After about 2 weeks you get better. It's all the frontal lobe said, hey, now everything is under control and we're going to get better. You get off narcotic, walk away out of the hospital. No narcotic addiction. No, everybody is happy, and this clears up. On the other hand, you're working in Walmart, and as you reach up there, the battery drops on your foot. It causes a bruise on the dorsum of your foot. It drops exactly at the area of the foot that has got what we call watershed zone. In other words, there are sensory nerves, the sural sensory, peroneal, superficial, and deeper neurosensory nerves intermixed with each other in the anatomical structure dorsum of the foot. The moment it hits that area, it causes electric short in those nerves. That causes several areas in the spinal cord to be stimulated, several areas in the brain stimulated, and that causes such a sharp pain that causes sympathetic reaction. Body says, hey, this is no joke, even though it's a little bruise, this is really bad dude causing the sympathetic response. Then you ask the patient, where are you hurting? He doesn't say exactly over the dorsum of the foot, a little towards the middle. He says, my whole foot hurts, my whole leg hurts, my whole entire right side hurts. As a matter of fact, this happened 3 months ago. Now I've got migraine headache, I've got dizziness, I feel unsteady, I fall, and in the same time, I don't know why I can't walk straight. It's cramping down on me. I get cramps at night. My right arm is getting cramped, and he walks in the office with you like that. The first case against him. Hey, give me a break. A little battery fell off your foot. On your foot. Why do you act like this? Trying to impress somebody, right? This is only because it's a primitive pain, and that's why pediatricians here, any pediatrician? Anyway, pediatricians can tell you when the child gets RSD, he responds exactly as I told you, very rapidly, very severely. Fortunately, because they have got growth hormone and all the other hormones better than you and me, they recover from it more quickly. These two systems fight each other. So this system is a non-specific system that responds in form of vasoconstriction, cold extremity, pain, and burning pain. And this other system is very localized pain and temporary and goes away. These two systems fight each other this way. I showed the somatic side on the left side of the spinal cord, sympathetic on the right side of the spinal cord, but they really are overlapped. We separated them so that we could understand. On the somatic side, it doesn't have to be pain. A little massage, a little moist heat, foreplay of sex, gentle touch. Like, why is it, I don't want to go into that, but cryptid part, one of the main reasons for cryptid is fetal alcohol syndrome, and the drinking mother who's really in love with Heineken, not the baby, so she doesn't even touch the baby. And because they don't have this input, the end result is that they get such a severe CNS depression, plus the alcohol for 9 months has pickled the brain of the baby, so they just die because they don't have. And the same baby can save their life by stimulating them, by hugging them. You save life by you're massaging them and so on and so forth. This other one, because it's accompanied by reflex muscle spasm, reflex vasoconstriction, reflex low threshold for pain, you can't touch them. This one, I can touch my wife's dorsum of the hand after 30-some years, and she said, oh, isn't that romantic? That's beautiful. And if I am very grateful for the RSD patients that came to me, and I thank you for doing your treatment and cut your hand, I said, don't do that, because the stimulation causes a non-specific generalized stimulation of the spinal cord. This is, to be very gross, this is sex, this is rape. This causes, during sex you can have a little painful stimulation, nothing wrong. Scratch my back, it's great. But this is when the next thing to murder is the biggest crime, is rape. It's nothing fun, nothing good about it, it's just very severely painful. How do these two counteract each other? Is like this. The proprioceptive means sensation of touch, vibration, fine touch, vibration, massage, ultrasound, all of those inhibit the anterior horn cells of the brain. It comes in and means the anterior horn cell is tight. Why is it when you give massage you relax like this? Because it inhibits the anterior horn cells and gives a signal to the brain, everything is okay, everything is fine, just relax, that's good. This massage I'm getting really makes me feel good. The cortex of the brain says relax. That's inhibitory. On the other hand, a sheer pain sensation that stimulates the sympathetic nerves is the opposite. It stimulates the anterior horn cells and anterolateral horn cells. There are two different kind of cells in the anterior horn. You don't understand about anterior horn cells. I'm talking about the gray matter of the brain. It's the anterior horn, front part of it, and dorsal part, which is the posterior horn. This dorsal is sensory, anterior is motor. Stimulation, sympathetic stimulation causes muscle spasm in the anterior part and vasoconstriction through the anterolateral horn cells. And the anterolateral horn cells are purely sympathetic. So the end result is when you get the sympathetic pain, you get the three things. A burning pain that never stops. That we have learned from the RSD patients. Nowhere in textbooks you could find that until recently it just starting to surface, that these RSD support group. They say it never stops. I wake up, it's pain. I go to bed, it's pain. I cannot get rid of this pain, it's constant. And also it's burning in nature because it is causing vasoconstriction that causes a stimulation of the small C fibers. That's number one, burning pain that never stops. Number two, withdrawal of the extremity, spasm and tremor. How many times have you seen an RSD patient that does this? Or just sitting there and just the leg is shaking like that? Those are more advanced ones. But usually when they come in, the hand is more like flexed like this. That is the constant stimulation of the withdrawal stimulation of the spinal cord. It almost is like a decerebrate. The arm is flexed and leg is extended. They walk like this. And yet, no Babinski, no hyperreflexia, everything else is normal. So you say, oh my God, this guy is putting it on. He's not putting it on. This is extrapyramidal. It's not extrapyramidal through the extrapyramidal systems to cortex. It's extrapyramidal topical. In other words, not only it stimulates the pyramidal cells, but also stimulates the anterolateral horn cells, and as a result causes tremor and muscle spasm. So burning pain, muscle spasm, and the third one is vasoconstriction, a cold extremity. Exception. Exception is that when you have a damage that is severe enough, and that causes a focalized total paralysis, like a sympathectomy on that nerve. Then you get a hot spot in the middle, which we call epaps. We're going to go through that in contrast to synapse. And then as a result, that center of it is hot surrounding its core. That confuses the thermography interpretation, bone scan interpretation, and all of it. I don't know. I hope I didn't confuse you more than I did. So, burning pain and the spasm. Now, when we get the burning pain and spasm, everybody is trained to first think somatic pain. Everybody has got, is supposed to have, presumed to have, according to the training. You're presumed to have one of the following. Either you're supposed to have a disc bulging or herniation causing radiculopathy, or if that's not the case, it has to be carpal tunnel syndrome. If that's not the case, it's Taliana palsy. If that's not the case, it's thoracic outlet syndrome. If that's not the case, it's nutritional or diabetic neuropathy. And that's it. All of them related to some sympathetic part, somatic part. But nobody is taught sympathetic pain. Because what we know about sympathetic pain is what we learn in the textbooks, the experience of the father of sympathetic RSD, which is Dr. S. Mitchell, the surgeon in Atlanta during the Civil War, that was seeing these poor patients that in a matter of weeks, they would undergo more stages 3 and 4 and have abnormal atrophy and hair growth and so on. We are looking for that, but you cannot find it in mild civil injuries. You find it in bullet injuries and in sword injuries called causalgia, but not mild civil injuries. So what happens then? Then the patient has MRI. MRI shows a little bulging. For example, patient has battery dropping on her foot. She has got 2 children. Show me a lady who has had 2 children and doesn't have a bulging disc at L5S1. Then you swing to have a baby that disc bulges. The surgeons have found the cause, go ahead and operate on the patient. The whole extremity and pelvic region is in sympathetic mode. They do an unnecessary operation, and the end result is that the operation becomes a new source of RSD. The patient is 10 times worse. Like there was, the Clinical Journal of Pain 2 issues ago had a statement by a great doctor, and the statement was saying, when 2,000 years from now they dig out our civilizations and they try to understand how we practice medicine, They find these people that were totally enamored and in love with this spine. They would keep digging this out, and they still would not learn the lesson that you usually don't get better. And only in our clinic and in the other pain clinics like Dr. Asimov in Miami, only 28% of chronic pain patients have this problem. 72% have other causes. And why is it? The order of events is that you do MRI, find a disc, operate, then you don't get better, forget it. It's all in your head. Give it to psychiatrist. Psychiatrist put the patient on Haldol or Valium and let them sleep in the closet, and everybody is happy. I'm not attacking psychiatrists. My conclusion is going to be you have to have multidisciplinary treatment. You have to have every doctor involved. Well, all the doctors are too small for this horrible disease. You have to have an anesthesiologist to do the block. You have to the physiatrist to do the physical therapy. In the same day as block is done, you have to do 6, 7 blocks at each session of treatment, matter of 10 to 15 days or whatever. And you have to also have somebody to detoxify the patient, to get the patient off all that Valium and Xanax and Percodan and Percocet and Vicodin and all the goodies that we give to the patients for acute pain. This patient doesn't have acute pain. This patient has chronic pain. So usually these patients end up having carpal tunnel surgery, the exploration of ulnar nerve, and especially because they have ischemia in the nerve trunk, their distal latency of the nerves are delayed. 1 operation, 2 operation, ulnar nerve, so-called tardive ulnar palsy operation, and she was supposed to have thoracic outflow syndrome surgery before somebody diagnosed that this patient had RSD. Matter of fact, 30-some years of neurosurgery and neurology practice, I have seen maybe 3, 4 truly thoracic outflow, and they were all vascular and not so much. Yeah. The reason these people get so much surgery for thoracic outlet syndrome is because all the muscles in the extremity go into spasm. The thoracic outlet triangle goes into spasm, and they look just like thoracic outlet syndrome. So the number one rule in this condition: diagnose early, be aware of it, look for it with those 3 descriptions I gave you, and first thing you do is cancel the operation. The next thing you do, get rid of the brace. Get rid of the cane, get rid of the wheelchair, get rid of the sling, stop the ice. Why? Because if you don't get this patient off his butt, excuse my language, and get him going, you have been less and less of that proprioceptive inhibition of the pain, and the patient will have more and more vasoconstriction and more spasmatic pain. Now, as you know, there are 2 different types of sympathetic pain. One is called SMP, sympathetic mediated pain, and the other one is RSD, reflex sympathetic dystrophy. And I'm going to try to help define those 2. The triad of the RSD are burning pain, as I just mentioned, cold extremity, tremor, muscle spasm. So the burning pain is afferent or sensory input into the spinal cord. Motor part of it, the efferent part of it is cold extremity, tremor, flexor spasm. We already have discussed that. We showed pictures of it. And the third part that you have to call it RSD is the patient has to act crazy or be crazy or drive you nuts. In this beautiful Puget Sound, this is the first time my wife and I came to this area, we find an absolute ultimate paradise, and you people better keep it secret. Beautiful place. In this large area of 100 and some miles, they have excellent medical centers and excellent medical doctors. You have Dr. Bonica, which is the modern father of subject of RSD and sympathetic nerve palsy. You have a great neurologist in this area who has done great research, has contributed a lot to this, but then all of a sudden, after so many years of listening to these not crazy patients, he said they're all crazy, there's nothing wrong with them. Why? Because that somatic pain I've said came to the neocortex. The sympathetic pain doesn't go at all to the neocortex because it was that modem, that system, computer system was put in before there was any neocortex. The highest it gets, according to all the anatomical studies that I have done, they have done and beautifully summarized. If you want to read it, I would highly recommend an article by one of the doctors from my alma mater, the Mayo Clinic Proceedings, October 1993, and his name is Dr. Bernard Rock, Benarrock, and he shows that every single afferent nerve input from the whole sympathetic system goes to only brainstem, frontal lobe, mesial temporal lobe, purely limbic system. What in the world is limbic system? Limbic means marginal. It's at the margin of the primitive spinal cord and brainstem on one end, which every worm, every fish, every cat, everybody has it, versus the neocortex, which is higher order of animals on the other. Right at the border of these two, or at the limb or border of these two, you get this complex system that's called limbic system. Stimulation of limbic system causes exactly what these patients have: insomnia, agitation, depression, poor judgment. If we don't have some of these manifestations of limbic system, they're not crazy, they don't have RSD. Anybody could have sympathetic mediated pain. Anybody who has sympathetic mediated pain could also have somatic pain. For example, in the case I was talking about, battery or falling on your foot, or injury to the elbow and so on, it doesn't swear that's only going to go pick the sympathetic nerves. It can also pick the somatic nerves, and as a result, when you do sympathetic block, you are taught in medical school, in your residency, if it doesn't get rid of all the pain, it's not RSD. That's not true. By doing sympathetic block, you get rid of the 90% of the pain, which is sympathetic. 10% somatic still will be there as a chronic. But that is not RSD. RSD has to have all this components. So what causes RSD? This we have already mentioned. That's other thing about somatic versus sympathetic, which would be the neuropathic pain. You know, I've mentioned about sympathetic versus somatic. You also call it neuropathic and somatic. The neuropathic means you have to have that pathological response to it. The neuropathic pain goes to both cerebral hemispheres. Everything about RSD is bilateral. The patient starts having a mild injury here, but starts having cold extremity and flexion on that side. Come on, give me a break. Nothing happened to your arm. Why do you act up like that? Or all of a sudden starts having spasms to both legs, because the whole sympathetic chain is bilateral. Also, cortical representation is bilateral in sympathetic, in the limbic system. So it's bilateral stimulation of anterior frontal temporal lobes and brainstem versus the somatic, which is purely unilateral. Now we go the limbic system. The limbic system starts from brainstem and goes all the way up to frontotemporal region, especially through median forebrain bundle. It is far more influential in our behavior than the somatic or conscious system. It's what Freud used to call subconscious, unconscious. It is the chemical brain. It's the hormonal brain. In our head, we have 2,000 million nerve cells, 2 billion nerve cells, almost as many glial cells, glue cells. They are just policemen watching the thinking brain, making sure nothing goes wrong with it immunologically or physically. But these 2,000 million nerve cells make a computer that's the most advanced computer, and I don't think how many thousands of years from now a human being can imitate God's work. Anything like that computer is. It has 3 different manifestations or 3 different modes of function. Chemical, through the synapses. And these 2,000 nerve cells, they're all separated from each other. Not 2 of them touch each other. They all have a little cleft called synaptic cleft, a little moat around them. So you stay on that side, I stay on this side, we'll exchange goods we want. I have too much potassium, I give you too much potassium, I need more calcium, you give me some calcium. That's chemical. Secondly, electrical. Everything that the brain does generates electricity, and that's the difference between a flat brain, dead brain versus all kind of alpha activity in the live brain. And magnetic. Somebody gets a car accident and becomes paralyzed from hip down. The only way we know this patient needs to have surgery versus not have surgery is not the X-rays or MRI, because MRI does not identify acute contusion, but stimulating, putting a magnet on their head and stimulating the cortex of the brain to see how, if the magnet goes through, that means spinal cord intact, don't operate. If it doesn't go through, you operate. Or why look at my wife? She's a beautiful Germanic girl, and I'm a dark guy and kind of mean-looking guy. The two of us have been in love with each other for 30-some years, and every day more, because we have an opposite magnet. Opposites attract and similar distract. You're working as a nurse in the same department, and you have another one that looks like you, acts like you, you're identical. Oh, you two can't stand each other. You've got one of them. So it's electrical, magnetic, and chemical. But on the other hand, it is full of hormones. The brain is the biggest hormonal gland in the body. And this hormonal activity exchanges all the biogenic amines, all the different growth hormone, endorphin, which we're going to talk about today, ACTH, etc., etc. And sympathetic system stimulates this entire system, and sympathetic pain, and messes up this entire system. Now, I'm going to take a break, but first I'm going to, this is the difference, this is all the studies that is full in, all over in literature. This is borrowed from great Dr. Bonica's book, and it shows that we just put color in it to make it more understanding. The green is somatic, goes to neocortex, and red is sympathetic, that goes to the limbic system. The more you learn that book, the more you learn from Dr. Bonica. Magnificent. Now, and by going through the brain and causing the emotional disturbance, meets the criteria of reflex sympathetic dystrophy. When you have that, you don't need thermography, you don't need bone scan. For God's sake, don't do MRI on these patients. All you're doing is you're adding more problems. How can you expect MRI to show the C fibers, small C fibers of sympathetic nerves? I mean, if I go to a medical room, I've got chest pain, do they do MRI on me? They do an Eindhoven EKG from 200 years ago, to put some electrodes on my chest, and they say, okay, you have a heart attack, go there, or no, you don't have a heart attack, you need to have this nerve medicine. The reason is because that computer I was talking about has got a hardware and a software. The hardware is when you have a subdural hematoma, a disc herniation, a brain tumor, an intracerebral hemorrhage, any of that. Cerebral atrophy, fetal alcohol syndrome, number one cause of fetal brain causing, number one cause of retardation, and attention deficit and conduct behavior, the alcohol, all of those can show on that anatomical test. But when it is something that is sensory nerve fibers or motor nerve fibers, it's not going to show on that test. So you're wasting your time, and then don't do the nerve conduction times either, because okay, you may find some slowing of conduction, but that's not related to that. Diagnosis of RSD, the clinical diagnosis of those three criteria. And then to learn something to make us all on board is that when the sympathetic, somatic nerves go into the clear-cut areas in the brain and spinal cord, sympathetic nerves end up in these chains, and these chains are constantly crossing across the midline. They are connected vertically. That's why sympathectomy never works. Maximum I've seen sympathectomy work was about 3-4 months. Shortest I've seen is 7 days. It never works, and it's useless. And the reason some people get better is because they're diagnosed early, and in first 6 months when you treat RSD, practically any treatment helps it if you do the right thing. After 2 years, the Workman Comp studies by Canadian government, the Division Department of Workman Comp, they assigned a bunch of doctors, and those all over Canada, they did a group cooperative study and showed that the success rate the first 6 months is somewhere between 80 to 85%. The first year, success rate drops to about 60%. After 2 years, drops to 20%. So it's not the mode of therapy. is how early it's diagnosed and how properly it's treated. So that is the reason why this RSD spreads up and down. That's why it spreads across. That's why RSD patients have, I'm sure a lot of you have seen, the patient has had a mild sympathetic nerve damage and constant complaint of chest pain, and their blood pressure is up, their pulse is high. That's because the cardiac plexus gets into action. They get dizziness and ataxia and blurring of vision and so on because of the vertebral arteries getting involved, and they get severe migrainous headaches because the vascular system are involved up there. I'm going to take about, if you would allow me, 10 minutes break. The rest of it is going to go much easier. The first part was the most concentrated part. Thank you for listening. What I'm going to present in the next session. I'm going to advocate very strongly, even though doctors should not be advocates, I believe. Unfortunately, about 5% of the doctors are so-called company doctors, and 5% are ambulance chasers, and both of them are disgrace to profession of medicine. Doctors should be taking care of the patients rather than being advocates. But I'm going to deviate from that and advocate certain modalities of treatment for this condition. It's not so much advocate as recommend or suggest. And what I'm going to say is that the only way you can take care of a chronic RSD patient, you can prevent and you can manage, but you cannot cure by the time they come to you because they're too advanced. And the way to do it is, number one, to detoxify them, get them off narcotics. Because as long as we give them narcotics, they're not Percodan, Vicodin, Percocet, any one of these strong narcotics are not only paralyzing endorphin, but proportionately paralyzing all the other things that the endorphin stimulates, such as ACTH, such as sex hormone, such as growth hormone, such as antidepressants that the brain makes, all of that. So you can't get to anywhere unless you get the patient on narcotics. So what do? These patients are in constant pain. I put them on Stadol, S-T-A-D-O-L, which is given, it was originally started, given for labor pain. It goes both in nasal form or injectable form. It is non-narcotic, not even controlled drug, Stadol, and it is, best part of it, it's a morphine agonist antagonist. It goes along with the body's endorphin because body's endorphin is a very, very small amount, doesn't bother it. But when you take, if you sneak in and get one of your Percocets with it, you get sick as a dog. So it's just like anti-abuse. And the patient either learns that either he can have the relief without withdrawal with a Stadol, or go back to his old habits and get sick. Secondly, Stadol alone is not going to do it. Sometimes we add Toradol to it. But secondly, the treatment of choice for all the chronic pains is antidepressants. And you give antidepressant not because the patient is depressed. About 20% or so of RSD patients are not depressed. They're mad as hell, but their profile doesn't come back as depressed. And these patients, we give antidepressants always because antidepressants are treatment of choice for chronic pain. Why? The same way that they function by being antidepressants, by improving the chemical exchange at the synaptic cleft, by pushing the serotonin in and keeping norepinephrine out. In the same way, they raise the threshold of pain. Pushing your serotonin in, you raise the threshold of pain. That's one of the best ways to get rid of the pain. If you push norepinephrine or dopamine in, then your threshold of pain drops. You become angry and painful and depressed. So treat the chronic pain with antidepressants. Not all antidepressants are alike. Tricyclic antidepressants that are most commonly used, only one of them is very good and effective, and that's desipramine or norpramine. But I would not start these patients on tricyclic antidepressants because tricyclic antidepressants make the patient lazy. We don't want to have a lazy patient. This patient already has been immobilized too much, has been sitting on his duff, and you want to get him going. So you don't want to make them drowsy and lazy. You want to get them going. So the new serotonin type of antidepressants are most effective. The antidepressant of choice is trazodone or Desiril because it provides more normal REM sleep, rapid eye movement sleep, and during the REM sleep, that's the time when your memory function is put back in place. That's the time when your endorphins are secreted and sex hormones and all of that are secreted. You wake up, this patient is mental rest. What happens? Oh my God, why did you wake me up? That was the sexiest dream I was having. But you don't remember it the next day, and yet it's doing all the good job. It is allowing, it's keeping the cortex busy to allow the brainstem to heal itself and put the files in the hippocampus in the temporal lobe back together. So you need that REM sleep, and the patient with RSD cannot get better if he's always watching the late night show because of pain and cannot go to sleep. So stay on antidepressants. The next thing is muscle relaxants. They need muscle relaxants because of the spasm and so on, but not every muscle relaxant works. Soma is okay. Robaxin is absolutely useless. Robaxin is only helpful because it has a very, very short half-life. Only helpful in acute injuries. Flexenil is all right, not as strong as Soma. And the most effective muscle relaxant is the one that slows down the function of anterior horn cells and anterolateral horn cells. It's even more effective than Valium, which Valium we know that's the biggest known one. I'm going to tell you why. It's called baclofen or diuresal. Matter of fact, some of these patients have so much problem with it. Instead of morphine pump, we put baclofen pump in their back, in this heart. But none of this will get you anywhere unless you detoxify the patient of narcotics, and as importantly, of two other most addicting drugs. The number one addicting drug in the world is alcohol, and assume every one of your patients is a closet drinker unless proven otherwise. Because alcohol is used to relieve pain. I said, Doc, what can I do? Nobody can do anything for me. I've had 5 operations. All I can go do is to have 6 packs of beer to just go to sleep. When you have 6 packs of beer, you are anesthetized. You completely are pain-free for 3-4 hours. 4 hours later, you wake up madder than hell and more painful. Because the alcohol is the ultimate addicting drug. Because in 1 or 2 ounces of alcohol stimulates endorphins. And also is a very strong stimulant of dopamine system. That's why so many Nobel Prize winners in literature and poetry and the ones who write the greatest books are advanced alcoholics. Look at Ernest Hemingway. I can just stand here, name. You don't need to bother. We don't need to name names. We know who we are. I'm not alcoholic, I'm not a member of AA, but I believe that everybody has the potential of being alcoholic because it is such an omnipotent drug that nobody is immune. The only ones that are immune of alcoholism are the ones that their system makes them too sick. They're allergic to it. They go and will cough or rasp in the back, wow, like that. Those are the ones I know they don't take. Everybody else takes. And everybody else in the world is addict. You're all addicts. I'm workaholic. What the hell am I doing here? Who paid me for anything for here? Why did I drop my practice? Why am I at the other end of the world? Because I love to show off, but most importantly, I want to spread the word. So that I'm spreading the word so that the people would not operate on these patients, would not give them Valium, Xanax, and Percodan, and Percocet, and Vicodin, etc., etc. Oh God, my nightmares. The morphine patch, that the oh my God. You know, in any way they can find, they overload the patient's system with narcotics. You have to get them off those. You have to get them off benzodiazepines. And diet, which I'm going to refer to briefly, and exercise. You never get better unless you get rid of all those assistive devices. Now let's go back to where the horse is. Now that we have got all these other things, what causes RSD? Normally, the two systems, somatic versus sympathetic system, balance each other off. Function of sympathetic system was best described about 150 years ago as the guardian of the internal environment. million-term, meaning that if you don't have a sympathetic system functioning, you are not a human being anymore, you're a fish. If the temperature outside is 30 degrees, inside temperature will be 30 degrees. If the temperature outside is 110 degrees, inside temperature will be 110 degrees. You put the fish in 110 degrees water, and they usually die. You and I don't die. We keep the inside temperature around 98, 99, but the outside is still 120 degrees. So it controls the temperature to keep a balanced internal environment. Number two, it has a major role in immune system by keeping the balance of the internal environment. And that's why in the classification that latest classification of four stages of RSD, the fourth stage, very frequently patients have immune system disturbance. They get frequent colds. They get problems with lupus or neurodermatitis or severe intractable neurodermatitis. The whole system is all torn apart. Number three, it is controlling the fight and flight system, because the only way you can keep your internal environment protected is by running away when you know you're going to lose and fighting when you know you're going to win. And that is the job of the sympathetic system, which is the blood pressure up, make the pulse go fast, as a result, alpha-1 noradrenergics are the number one tool, the gun that sympathetic system uses for its function. It does have about 10% of the fibers also are parasympathetic or as cholinergic, as we were discussing with the neurosurgeon here, that some of them, they get very bad hyperhidrosis from that. But the 90% is alpha-1 noradrenergic for the fight, for the high blood pressure and rapid fall. That's why in the stage 4, what happens? What's the end result of what happens to these people? They usually die of heart attack, stroke, suicide, more common than heart attack is number 1, suicide is number 2, stroke number 3, and immune disease disturbance and cancer or hyperimmune response is number 4. Now, as the system becomes more active, it causes a vicious circle. And this vicious circle was described in 1940s in detail in medical literature, but nobody bothers to read the 1940s literature. I can't catch up even with 1994 New England Medical Journal, let alone 1940s. But this was in detail reported that when you have the constriction of the blood vessel, and that causes inactivity or constriction of muscles and spasm. That causes inactivity. The inactivity results in less input of the good touch pain. That it decreases the inhibition on anterolateral horn cells. As a result, causes a vicious circle of more vasospasm, more tremor, more spasm, and the patient keeps getting worse. Hence, you cannot get rid of this disease unless you do sympathetic nerve block combined with physical therapy. I believe the number 1 treatment in RSD is physical therapy. Physical therapy would be in the form of making them move it, increase the function, give them muscle relaxant, give them the non-narcotic pain medications, but move it so that you can increase the proprioceptive function and stop this vicious circle. This is called disuse RSD. The RSD becomes perpetuating because of the spasm. The commonest form of it is they have had a minor injury, but they have been put in a sling. Ice has been applied to increase the vasoconstriction, and they are put on narcotics. They're inactive, so they get shoulder hand syndrome. The whole thing freezes. But something originally started at RSD. This disuse, you see it when the origin is usually in the heart, like a heart attack, or stroke, or multiple sclerosis causing a plaque of demyelinating disease and causing an electric short in the nerves, or something remote from the area of being affected.
You don't see the source, but you see only the reaction. The source, when it is in periphery, it's easier to diagnose. Now, this patient, for example, thermography shows, incidentally, I'm not advocating thermography. I told you that you can make diagnosis without the thermography. But thermography helps to have more knowledge of what's exactly wrong with the patient. Is it disuse, or is it a damage in the area of the patient who has got disuse? All you see in the thermography is such a cold extremity you can't even see the feet, for example. On the other hand, if the lesion is in the periphery, I mentioned the areas that are most common that you get RSD in civil injuries. In war injuries, it's usually a sword or bullet in the brachial plexus, upper part in the larger nerves. But in the civil injuries, it's usually distal. In the areas where you have got three different nerves being in close proximity to each other. Radial nerve, sensory nerve is right here, median on this side, ulnar on this side. These three, one little cross cut in that area causes RSD because the whole system of the whole brachial plexus all of a sudden is turned on. Same thing with dorsum of the foot, same thing especially with the knee. Knee is one of the biggest culprits. And when you get knee injury, the first thing that happens, you get back pain, and you get such a spasm, it bulges the disc, and that's when they jump in and operate on the patient. Same thing with elbow. You've got ulnar nerve, median nerve, and proximal sensory nerves in that area. When this happens, you get what we call EPAPS, E-P-H-A-P-S. Now, EPAPS is the opposite of synapse. What in the world is synapse and EPAPS? We know the synapse, that cleft that separated everything, that you had to do interchange of chemicals and magnetic and electrical exchange. In EPAPS, there is an electric short. The best example of EPAPS is epilepsy. You and I can get very upset, and our brain, when you record the EEG on it, it shows a lot of fast beta activity, very fast activity. Or we can take Ritalin or alcohol or Valium that causes lack of inhibition of the cortex and gives you a lot of fast activity. But we don't get a fit, you don't have a fit, you don't have a seizure. On the other hand, if we have a car accident, or if you have, for example, measles in childhood or something like that, it causes some damaged and destroyed or partially dying nerve cells. Those partially dying nerve cells don't have their synapse anymore. They're connected to each other. The moat is gone, so they share the electrical charge with each other. You get the 100,000, 200,000 of them together and get all the electric charges shared, you get what we call an Eeg Spike, a huge electrical discharge. And that electrical discharge causes you to have fit. It can be in the parietal cortex, then you get a sensory fit. You say, you don't shake like this, but you say, ooh, this feels crawling all the way up, goes up here, and then the patient gets a grand mal seizure. This happens also in periphery. This specifically happens in RSD. If it is in the brain, like I mentioned, in stroke, or in multiple sclerosis, or in spinal cord injuries, or diabetic vascular lesion in the brain and spinal cord, you can get the EPAPS, or electric short, in the brain and spinal cord. On these other industrial injuries, or civil injuries, it happens in the periphery. What happens is that even in the periphery, the nerve fibers are insulated from each other with myelin, with the, just like wire, cover on the wiring of the, insulators. Insulators become damaged, then they start exchanging electricity and causes a sharp pain. That's why they get, not only, they say, besides this constant pain, I get these sharp shooting pains. And that's why anticonvulsants can help them partially. This EPAPS is prerequisite of RSD to be originally to start. But a lot of times, the nerve heals itself. By activity and circulation, it heals itself, and it's gone. And but that's why in the first 6 months, the patients get better. Everyone thinks RSD means it's married to my pain clinic for the rest of my life. That's not true. The first 6 months, they get better, they go and never come back. But if it is improperly treated, that disuse causes vasoconstriction and causes this constant electrical input. Do I make any sense so far? Thanks. Lovely. In this FAPS, the small myelinated fibers, or practically unmyelinated fibers, which are the C fibers, which are the small pain fibers, primitive pain fibers, that are purely sympathetic nerves, sensory nerves, they have a lower threshold of pain. They become more stimulated by this electrical stimulation than the larger fibers that are too stagnant and takes a lot more stimulation to stimulate them. So even when you touch the skin, the touch doesn't stimulate the large fibers, but enough to stimulate the small C fibers, and then even a touch becomes painful. How many times your patient comes to your office, doesn't have a shoe on, where a patient's barefoot, has got a little string on top or a little tape or something, or they say, at night I have to leave my foot out of the bed sheet, I cannot stand. Or you touch them, don't touch me. Because that stimulates purely sympathetic fibers. You notice now, instead of green and red being equal, the proprioceptive and somatic input being equal, you have a lot more red than green. So every fine touch causes a new sympathetic stimulation. The treatment in this situation would be physical therapy, sympathetic block. Why the sympathetic block is so important? You cannot get these patients better than sympathetic. I think that a team of treatment of RSD, the physiatrist or physiotherapist and anesthesiologist are the number 1, 2. The rest of them, you try to get them out of the way. The ones who give you narcotics and stuff like that. But you also need the psychologist to sit down and talk to the patient. Not to prove to you this is all in his head. Yes, it's in his head. It's constant input of pain in his head, and because he's got an FAPS. So the reason sympathetic nerve block is important is that you drop down the input of the red fibers so that the green fibers or the proprioceptive fibers would have a chance of relaxing the muscles and helping the patient get better. Narcotics, all they do, they make you more inactive and more pain. Alcohol the same way, couch potato. This is a thermography of 3 different nerves. You've got the peroneal nerve, the sural nerve, and superficial and deep peroneal nerve here. The patient has an object drop on the foot. All of a sudden, the whole thing is scarred up, and it causes a disruption or the FAPS that we are talking about. Now, this FAPS, when it is severe and it's peripheral, it causes what we call causalgia. There are so many different names for RSD. Causalgia, shoulder hand syndrome, RSDS. In my writing, I've shown about 24 names. But when you get that FAPS in the area of the peripheral nerve or in the area that is damaged, you get a different course than the disuse atrophy. Do you remember the disuse had a mild injury, but it was becoming worse because of inactivity. The disuse, the stages 1, 2, 3, and 4, is very slow and very mild. When you have that FAPS and you treat it wrong, instead of a matter of months or years, you're talking about a matter of weeks or days. So you can't tell the patient you cannot have stage 3 because you only had the injury 3 months ago. It can happen on the more severe ones. In stage 1 and 2, you have got stage 1 is purely dysfunction. It means that there is no trophic changes. There's just function is improper. Pain and burning pain and inactivity. Stage 2, you get vasoconstriction, cold extremity, hair loss. So we call it, instead of dysfunction, we call it dystrophy, spasticity. Stage 3 is heralded by atrophy, but don't call it stage 3 only if the patient has gross arm that looks like claws of a bird. The atrophy is usually very mild, very minimal on one side of the versus the other. You do surface EMG, you see one side has got far less electrical discharge. Stage 4 is what I was talking about, where you have all kinds of problems. Between the stage 3 and 4, you get especially the complication of Sudex atrophy. And Sudex atrophy means that you get such a severe osteoporosis that causes fractures of the bone. The reason is because in RSD it's not just vasoconstriction, it is surface vasoconstriction and deep vasodilation. It's just when you go, all of a sudden you go out, your temperature outside is only about 20 degrees, and you go out from 72 degrees temperature outside. What happens? The surface, because of sympathetic system, the surface becomes cold, but the inside gets heated up. Your blood pressure goes up, your pulse goes up, so that you would generate heat in your body. And as a result, it causes a washout of the bone and causes osteoporosis and fracture. The fracture is not at all because of weight bearing. It's because of lack of weight bearing. Because the less you carry the weight on your extremity, the more osteoporosis, the more fragile the bones. It's far more commonly seen in diabetics. As a matter of fact, in my experience, diabetes is of all the diseases, diabetes is #1 cause of RSD. We people see it in our type of acute practice because of industrial injuries, we consider trauma as the cause. But in diabetes, because you have vascular problems, then you get, and especially vascular diabetic neuropathy, you are much more likely to get Sudex atrophy and fracture. These patients who have fracture, you've got to make them walk on that broken bone. You give them pain medicine and make them walk. If they don't walk, they're going to have more and more fracture until somebody has to amputate their leg. And amputation in RSD, there should never be, unfortunately, there is one of the famous clinics in this country has got about 7 cases of malpractice against it because of repeated amputations they have done in the past few years. Essentially, nothing in RSD is malpractice, because the reason is because if you are in Zululand and you're practicing witch doctor, how can it be malpractice? Malpractice is deviation from standard of practice. RSD is mismanaged all over the world, so how can it be malpractice? So these people, they amputate, and once they amputate is the legendary head of Medusa, the Greek mythology. When they cut the girl's, mean girl's head because she was so mean, the head was cut off, but every hair changed to a snake. When you cut the extremity, every somatic nerve trunk is already vasoconstricted and sympathetically in the sympathetic mode. Every one of them becomes a source of RSD. Patient has one little damage in the dorsum of the foot caused this problem, now has got 12, 13 major nerves. Then they commit suicide and you never hear from them. Hey, you never came back anymore. Once you get them walking under the influence of pain medication and muscle relaxant, it all of a sudden decreases circulation in the deep and increases in the surface. Because it is, you're counteracting in activity, and as a result, the bones heal. They heal very ugly. One dorsum of the foot is just bulging out like this. Ugly looking healed bones, but at least the patient has not lost the extremity. So the reason I'm showing these stages is don't expect so many times I get in the position, how can this patient have RSD? Isn't it supposed to be, according to such and such textbook, that they're supposed to have loss of hair? Abnormal hair with fingernail growth, shiny skin. Did the patient have any of these? No, sir. Sorry, doc, I didn't hear it. Did the patient have any of this problem? No, he did not have hair loss, he did not have skin changes, he did not have osteoporosis, he did not have bone fracture. How can it be RSD? Well, if you look for that kind of RSD, any fool can make that diagnosis. But in stage 3 and 4, what can you do for the poor soul, except for morphine? The way to diagnose the RSD is stages 1 and 2, then you cure it. So don't go according to stages religiously. They can accelerate, decelerate, and bypass even in the case of the hepatic RSD. How in the world do you expect a patient to have IQ disturbance? I mean, when you send them to for psychological testing, I mean, is it supposed to be, you're supposed to be an Einstein not to have, not to have RSD? I mean, what the hell is that? You send them to psychologists. The only test I expect from psychologists to do is to do Halsted-Rayton test. That tells me if some part of the brain is disturbed, or if more of the limbic system that I expect, or nothing wrong with the brain part. That gives me information. MMPI, they're all supposed to have abnormal MMPI. MMPI was started in 1960s in Minnesota Multiphysics, University of Minnesota, and everybody considered it just like stupid IQ, which is the worst test. I mean, what's my IQ? What's my blood type? What the hell do I learn from that? Nothing. Unless I'm or IQ of 170, which may give me a big head, I'm a troublemaker. But MMPI was supposed to be solid, invariable. How can it be solid and invariable? Prove that either it's all in your head or it's not at all in your head. If you have a constant input of pain for 3-4 years that you've never had any sleep at night, you're supposed to be depressed. You're supposed to be somewhat paranoid. You're supposed to have poor judgment. You're supposed to have severe neurotic tendency because somebody has put a pair of pliers on your nerve and pinched it for about 2-3 years. And anybody would go crazy under that torture. MRI, definitely. Bone scans and thermography are very confusing because RSD is bilateral. The patient has got right hand injury, left hand becomes hot. Because this one is constricted, the other one is reactively vasodilated. So they become confusing. X-rays, actually X-rays are much better than CAT scan and MRI. Far cheaper, and they show you if there is a fracture or osteoporosis. But the anatomical tests usually are used. Now, as RSD spreads, it spreads the sympathetic chain, it spreads to the head and neck, and then it causes tinnitus. Have you seen RSD patients saying buzzing in my ear, or dizziness, severe vascular headache? And interestingly, when you get to the source of the RSD and give a muscle relaxant, all of that goes away. Another thing in this regard is that the patient may have RSD in upper extremity and yet have neck pain and headache as the main manifestation, or in lower extremity may have nothing but back pain just before you're going to do an unnecessary operation. The reason is because this muscle spasm spreads all the way to the neck and all the way to the back. Sometimes it's only the right foot and the patient has mainly neck pain and muscle spasm because the whole muscular structure in the spine goes into spasm as a part of the RSD. Sometimes there's a minor neck injury that causes the problem, and that minor neck injury is in the upper cervical region and it stimulates the substantia nigra, the sensory posterior horn of the gray matter, which is overlapped by trigeminal nerve sensory nerves. So the patient has got a mild neck injury but causes of dizziness and severe headache. In such patients, and also in patients who have got RSD in the extremity but they have severe neck pain and headache or low back pain, we can treat these people with prolotherapy. Very effective, excellent treatment, as long as just the moment the patient gets better, don't send them to have neurectomy. Neurectomy, cutting off these nerves, only causes new source of pain. But what you do with prolotherapy, you inject the area that is stimulated, that is, see the nerve that's injured, or the spasm causes kind of jamming of the vertebrae, especially articular facets that are responsible for lateral motion in the neck and back. That causes irritation of the nerve, posterior sensory nerve, which causes a vicious circle. You go in right adjacent to the articular facet and inject it with a combination of little small amount of depomedrol and large amount of marcaine, and then it just like a nerve block, just like a sympathetic nerve block. The patient gets better, then you start follow it with traction, moist heat, and the patient gets better. Now, harmful treatments. Make sure if in your team, pain team, don't allow a psychoanalytic psychiatrists or psychologists. Anybody who starts giving a report saying that in his childhood he was molested and punished by his mommy, or his mommy played with his genitalia and he still remembers it, that is baloney. The patient was perfectly normal before the patient had RSD. Try to have utilize people's psychology and psychiatry that are more post-Freudian. Just get rid of this genital orientation of barbaric Freudian thing. The only place in the world that still is very popular is in Wall Street in New York, among people who make so many millions of dollars. They want to go to the analyst data and talk to him. The rest of it is just useless. You can't talk these people out of their pain. But you need a psychiatrist who understands the different side effects of psychotropic drugs, and you need a psychologist who's willing to talk to them, give them a group therapy, make them, pep them up and help them get better. Of the benzodiazepines, you know what I'm talking about. Valium, Xanax, Halcyon, sleeping pills, and so on and so forth. The only one that we have defined that is safe is clonopin. Clonopin is not, first of all, it's a good anticonvulsant, not that because I started in 1967 in the United States, but this, because it does help with the spasms, and it is not, it doesn't bind to the benzodiazepine receptors in the brain. So you can safely get them on or get them off the benzodiazepine. Now, if you don't give a sleeping pill, then what do you do to help these patients get some rest? The best sleeping pill is Deziral or Zoloft, or if all these others fail, then you can put them on the Zipramine. As I said, the Norepinephrine is very effective in these patients, not as effective usually as the rest of them. Marital counseling is important. These people drive everybody nuts. If they're you and me nuts, they drive the spouse. It's very important to have support of the family, understanding of the family. Settling the case. One of the biggest problems with the civil cases is because a lot of them are workers' comp. And I don't need to tell you what a complex situation you have here. And both sides are bad. Plaintiff and defense are both bad. The lawyer doesn't want a patient to get better because he wants to have a case that will make him a millionaire for the rest of his life. And the provider acts like, you know, all of you are my enemies. You don't believe in RSD, you have found a doctor who says there is no such thing as RSD. So you're much better off settling the case and leaving the medicals open. Tell the patient, you don't need to get $200,000 because you get $200,000, you spend that matter of 2-3 years in your medicals and then you have left nothing. Then you go on Medicaid, which is the same as no insurance. But settle the case by the amount, let the medicals be left open, then everybody is more cooperative. We get that impetus of the patient not being active away. The patient goes from my office to the lawyer's office, the doctor says, hey, don't move your arm because they're constantly monitoring you. One of the things that insurance companies do is monitor, okay? They're supposed to, they have to. But if they monitor and the patient is not using the cane, the patient loses the case. They say there's nothing wrong, he doesn't use the cane anymore. But they don't mention the doctor told him not to use the cane. That's kind of a messy situation. Okay, I'm almost done. I promise you. Okay. There are three different kinds of insomnia these patients or any other patient has. One is depression and pain depression type of insomnia, which happens by a patient going to sleep but repeatedly waking up. Antidepressants and chronic pain, repeatedly waking up. The other one is anxiety and benign type of depression. Insomnia. The patient can't go to sleep, just constantly stays awake, but once they go to sleep, they're exhausted. That's anxiety. On those anxiety ones, the best treatments are Buspar and Melatonin. It works very well for this patient. The third one is you see it in later stages of RSD, but also you see it in elderly people. Hell, I go to bed 1 o'clock in the morning dictating until late. My brain is up 5, 6 o'clock in the morning. I remember for years, until about 10 years ago, nobody could move me out of bed. I had to have 2 alarm clocks to wake up. But as we get older, you get the early morning insomnia. That's a part of lack of frontal lobe inhibition. And in those cases, usually you don't need any medication. What you teach the patient is to have a little siesta in the afternoon. Also to realize that as you get older, you need less sleep. Of all the benzodiazepines, the worst in the world is number one, the most guilty one is halcyon. And once you're married to it, you can never come off it. Next is Ativan and Xanax and Valium. Not in that order. Valium is the next worst one, then Xanax and Ativan. What makes it bad or worse is this work that we have done. It's in my book, but also we did this on detoxification of the patients. And we noticed that, for example, to get the patient off the clonazepam or clonazepam, it takes only 2 days of withdrawal problem. You get the patient off triazolam, the halcyon, 68 days, if that. You come down to these other ones, diazepam, Xanax and halcyon, and Xanax and Valium and Ativan, again, very difficult to get them. But you have to do it, because you need to give that poor endorphin a chance. How do you give a poor endorphin a chance is the last thing I'm going to talk about, and I'll let you nice people go. I've been talking about this, I don't have time. I just want to go directly to the endorphins. Your goal should be allowing the brain to do its own hormonal secretion as best it can. The difference between endorphin and exorphin, endorphin, enkephalin, dynorphin, etc., many different kinds. Dynorphin is more important in the peripheral endorphin system. Enkephalin is more central. The endorphins, compared to exorphins, the only thing they have in common is pain relief. They are analgesic. The rest are opposite. Antidepressant, endorphins are antidepressant, and exorphins, no, they're depressant. The strength of the dosage, endorphin is 100 to 200 times stronger than exorphins. It's 100 times stronger than fentanyl, and fentanyl is practically 100 times stronger than morphine. So, because it is stronger, the body needs to make it in small doses, nanograms, tiny billionth of gram, rather than milligram or microgram. On the other hand, exorphins are 100 to 200 times weaker, so you have to give 100 to 200 times larger dose. So once you give the narcotics by mouth, injection, skin, any of these forms, intermittently, or even IV, PCA, patient-controlled analgesia, which is only indicated during the 7 days after operation, or cancer patients. When you do any of those, you're flooding the system with such a large dose of clumsy, weak narcotic that every 4 hours or 3 hours or so, the narcotic is gone, and definitely the brain has stopped making endorphins. It's so strong that if the brain also makes endorphin along with that narcotic, the patient will never wake up. It's shepherd's death. They just die. So after 4 hours, they have no pain medicine in the system. The patient may have been cured, but the only way lack of endorphin is brought to your attention is pain all over the body. So then you have a real pain, severe pain. And also you're depressed because your antidepressant endorphin is not good. The dose release in endorphin is microjet. Very tiny amount that only with histochemistry you can recognize it. Whereas in other forms of narcotics application is flood irrigation. A lot of base, a lot of amount, and a lot of severe withdrawal. That is the reason we advocate infusion pumps. We call it morphine pump. Rarely, sometimes use morphine, sometimes Dilaudid, sometimes fentanyl, whatever. Infusion pump. The reason is when you put the infusion pump, you try to imitate endorphins. You give the dosage of 1.5 day dose of narcotic dripped into the spinal fluid in 30 days. Nurse goes once every 30 days and injects it through the back, or the doctor. But because the dose is so small and it's drip irrigation, it's imitating the endorphin, so you don't have withdrawal. and you don't have depression, and you don't have treatment-caused pain. And these are the cases that you've done everything else, and you're humble enough to say, okay, either the patient has to be on narcotics and commit suicide with it, or be severely depressed, or has to be on this drip medication. I don't have time to go to the rest of them, but once the endorphin is suppressed, the whole appetite, the whole well-being of the patient is messed up, and the immune system is messed up too. So the final tool in management of RSD in a severe advanced cases is infusion pump. I'm all done practically, except for one or two words about sympathetic blockers. Do not use beta blockers. The beta blockers are used commonly in migraine, but even in migraine patients on the go. No, 20-some years ago I stopped using Valium, and about 15 years ago I stopped using Inderal, migraine or no migraine, because Inderal has got too much problem with fatigue, depression, decreased libido, decreased sexual function, irritability, sleep disorder, drop of blood pressure, etc., etc. Best blockers are alpha-1 and alpha-2 blockers. Alpha-1 blockers, one of the most benign and best tolerated alpha-1 blockers is Hytrin, especially if given at night. Clonidine patch is an excellent alpha blocker, and we use it all by mouth, or minipress by mouth. For example, the people who have interstitial cystitis because of RSD, they have got spastic bladder, they have spastic gut. We give them minipress with clonidine, and helps them a lot. The patients who have got RSD focalized, we put the clonidine patch in proximally, they change every 3-4 days. Alpha-2 blockers, Yohimbine or Yohimex. Yohimbine, this is what we learned from the American Indians in Arizona. And as the American Indian would get old, and he started losing his sexual capability, usually he lasted about 70 years. The civilized Western world man loses about 50 years because of alcohol. But even then eventually it slows down, so they would just get the root of the sagebrush and just chew on it. And they would get a nice erection because it's loaded with yohimbine, which is an alpha-2 blocker. It congests the extremities and as a result congests the genitalia. So when I give prescription to my lady patient to go get the yohimbine, that pharmacist is laughing. What do you want? Do you have some problem with your erection, or you get it for your husband? No, we give it because it causes, increases the circulation, not only in genitalia, but also in the extremities, and helps the patient. It's nicely tolerated. Of these alpha blockers, the ones that I like most are dibenzinin. It's excellent in severe cases. Dibenzinin, given it's just like anticonvulsant. When the patient has got a bad seizure, they can tolerate a lot more anticonvulsant than the people who don't have seizure. And the same thing with dibenzinin. You and I take the dibenzinin, you get flat. Your blood pressure drops to nothing. But these people, when they have bad RSD, hepatic or causalgic RSD, they tolerate it very nicely. And it's the best, most effective of all of them. In that horrible situation that people bombed the embassy in Beirut, there are a lot of nice young Marines were injured in that situation. And dibenzinin worked beautifully in this patient, saved them, majority of them, practically all of them from sympathetic. So it's very effective. Don't be shy about using blockers, and the best thing to do is first do the sympathetic block and then follow it by these others. Now, one last word about diet. You cannot expect the patient to get better if you're pouring some little antidepressant here or some little alpha blocker there, but the patient also is eating foods that are increasing the sympathetic function. The number one guilty one is hot dog. More, just as important, but even more serious in regard to withdrawal is chocolate. Not because chocolate has got caffeine in it, Chocolate is addicting because it has got phenylethylamine in it, which is very similar to cocaine, very stimulant, gives you a big pep. Being chocoholic is practically as bad as being alcoholic. So it's an addicting drug, but also phenylethylamine increases the level of tyrosine and in itself directly stimulates the sympathetic system. So you've got to get off chocolate. Period, paragraph. No chocolate in these patients. Hot dog, because it's got nitrates and it just messes up, it stimulates the sympathetic system, also stimulates the formation of tyrosine. Also, the things that your mom told you is good for your health, which is absolutely baloney, such as liver, baloney itself, kielbasa. The kids in China are dying from starvation. You better eat your liver. Why eat the liver? The only thing is in the liver is a lot of iron, which is more dangerous than calcium because it's oxidant. A lot of cholesterol. Big deal. Everybody talks about cholesterol, and they're really growing out of proportion. I would rather just eat all the cholesterol from the food it sounds from all the fish. It pushes my good cholesterol, protects me against the bad cholesterol. But there is no such thing as good iron, if amount that you get in the liver. There is no such thing as good uric acid that you get in the liver, and especially that all the tyrosine you get. How can you expect 0.1 milligram clonidine treat your patient if the patient sits there and has a big steak or a liver? That's the equivalent of about 20, 30 pills of clonidine. So let's get with it. Let's stop being such knowledgeable doctors that only drugs and surgery will take care of it. You have to go on a diet, which is 4F diet, fresh fruit, fresh vegetable, fish and fowl, and no 5 C's, candy, cookie, chocolate, cake and cocktail, so that your blood sugar doesn't fluctuate, and as a result your norepinephrine system doesn't get all stimulated. It's baloney when they say don't eat before you go to bed. Yes, you are not supposed to eat all the, the kidney is the latrine of the body and liver is the toilet of the body. You're not supposed to eat the toilet, or the steak, or the martini and steak, or roast beef. But you have to have a specific, all of us, not just our specific, all of us have to have a snack at bedtime comprising of 3 things: fruit, bread or pasta, and dairy products. Everybody is scared of dairy products. Everybody says, oh no, cheese has cholesterol. Baloney. Mozzarella cheese, provolone cheese are extremely low in cholesterol. But they don't eat the cholesterol. Say, no, also I'm allergic to milk. Well, I can't eat any dairy product, so they put that butter in it. Where did that butter came from? From some cow, yeah? So the main thing is that switch the butter to cheese, or frozen yogurt or yogurt, and have fruit and have pasta. That way your blood sugar stays steady during the night. The reason for pasta and bread and so on is because, and cheese is because they're loaded with tryptophan, which is best sleeping pill, best antidepressant, best blocker of the coronary pain. I want to thank you for being so nice and listening to me.
0.9 is normal. 3% is more than triple the usual concentration in your blood. 3% doesn't sound like much, but when you compare it to normal saline, which is only 0.9%, not even 1%, then it's more than triple. That makes it a hypertonic solution. Remember, we're measuring it against the body.
So you give that to somebody with too much fluid?
Hypertonic, you give to somebody with too much fluid.
So it's just the opposite.
Mm-hmm.
That's what it's using.
Yeah. There's another variable in there, and that's electrolytes that affect that. We'll get to that.
It's getting really confusing.
No, don't worry about 3% yet. Just think of it as a hypertonic solution.
And so you give hypertonic when they're hypotonic. When the person is hypotonic, you give a hypertonic solution.
Yeah. When you give D10W, what happens to your urine output?
It would
The urine output actually will increase, right? Because they're putting more fluid into their intravascular space. That's too far down the line to think, huh? You don't have to think that far down the line yet. Let's give you some more examples. Of a hypertonic solution, another example would be TPN, total parenteral nutrition. TPN is your most hypertonic solution that you're going to give. That's why when your bag hasn't come up yet, you fill in with a little D10.
Can I go over that one more time? I feel like that. Now,
pace without any shortness of breath or chest pain, they could feel comfortable then resuming sex without having any negative symptoms. The number one stress after people leave the hospital is the irritability that patients feel because of wives, what they call nagging, watchfulness, doing for, and most of that is very unnecessary. If a patient has chest pain and the chest pain isn't relieved by nitroglycerin, then that person needs to call the paramedics and go and have it checked out. It may or may not be anything significant. The general aura of watchfulness is probably not that helpful. And in fact, I think that that's why an exercise program breeds the confidence that essentially replaces the watchfulness.
It's gradual. You don't just walk out of your house and you do something. But suddenly you discover you can do things. You can go back to a normal life.
I think it took me probably about 6 to 8 weeks before I felt that I could start doing everything I was doing before.
I would say my rehabilitation took about 6 to 9 months when everything, including play, golf, sex, food, habits, driving alone, going to the job site with confidence, everything came back within about 6 to 8 months.
The heart attack's back there in your mind someplace. You know, it's always there, but you don't live it and breathe it and think about it all day long. You just go on living.
Let's review some of the important points covered in this section. After recovering from a heart attack, the patient may need to make some major behavior changes in order to prevent another one. These might include giving up cigarettes, reducing drinking, controlling high blood pressure, and avoiding unnecessary stress. It may even mean changing jobs. Regular aerobic exercise is usually recommended for good cardiovascular conditioning, exercise such as fast walking, jogging, swimming, or bike riding. Diet may be even more important than exercise. A healthy cardiovascular diet would emphasize foods low in saturated fats, low in salt, and low in cholesterol. It should be clear then that the doctor can do only so much. When it comes to prevention of heart attacks, much of the responsibility lies with the patient.
As you know, HSTM has undergone several changes recently, and just like the healthcare industry, will continue to change. But we need your help to make sure our programming meets your needs, so we've established a toll-free 1-800 number. The number is 1-800-759-4786. Please invest a few minutes and take part in our telephone survey, then leave your comments afterwards. Don't miss this opportunity to let your voice be heard. Call 1-800-759-4786.
Results with open heart surgery patients have shown that survival rates and rehabilitation rates have improved dramatically. The nurse is a vital part of these results. Through preoperative teaching and coordination of preoperative activities, the nurse is directly responsible for the patient's care. Upon completion of viewing Part 1 in this 2-part series, the nurse will be able to state the goal of coronary bypass surgery, state the criteria necessary for such a surgery, describe the 7 preoperative problems affecting postoperative outcomes. You will also be able to assess the patient's pre-cardiac surgical baseline knowledge, explain the pre-procedural nursing care of the coronary bypass patient, state 4 purposes of anesthesia, list 3 purposes of cardiopulmonary bypass, state 3 advantages and disadvantages to the pump oxygenator, and lastly, describe the surgical procedure for coronary bypass. The goal of aorta coronary bypass surgery is to revascularize ischemic areas of the ventricular myocardium and improve ventricular function. To obtain this goal in patients, it's important to know the reasons for having coronary bypass surgery. The anatomical diagnosis must be established by prior left-sided cardiac catheterization, including coronary angiography, and evaluation of the left ventricular function should take place within 12 months before surgery. After evaluation is conducted, there are specific problems which require surgery. If the left main coronary artery has an obstruction of 50% or greater, with or without involvement from the right coronary artery, surgery must be performed. If there is a coronary artery obstruction of 50% or greater in 2 or more of the following, surgery must also be performed: the left anterior descending artery, or its major diagonal artery, the circumflex, or a major branch, such as the obtuse marginal, the intermediate, or the large posterior lateral artery, and or the right coronary artery. If there is just one obstruction of 70% or greater in the left anterior descending, or its major diagonal artery, in the circumflex, or major branch, in the right coronary artery where no other options other than surgery are available, then surgery is needed. If there is a coronary artery obstruction of 50% or greater in a major coronary artery and a problem with a valve or a septal defect, then surgery is also warranted. The last criteria for surgery involves patients who need a second bypass. The first situation involves any patient who has regained any of the problems we have just mentioned since their first bypass surgery. And lastly, if a patient has an unsuccessful percutaneous transluminal coronary angioplasty, they must have surgery within 24 hours following the failed PTCA. Before surgery, there are specific considerations the nurse should be aware of. These problem areas, if known ahead of time and monitored throughout the patient's stay, will not go unrecognized and cause complications. These considerations include pulmonary dysfunction, hematologic disorders, renal dysfunction, metabolic disorders, vascular dysfunction, nutritional deficits, and assessing all of the patient's preoperative medications. The patient has arrived at the hospital the night before his surgery to conduct all of the preoperative activities.
Oh, hi, Mr. Johnson.
Hello there, how are you?
I'm Marie Keneally, and I'm your nurse here before surgery to explain to you what will be coming up and that you ask any questions and give us any suggestions you want to give us.
A comprehensive assessment of the preoperative heart patient provides valuable information and baseline data for postoperative nursing care. There is a convergence of mechanisms occurring in the response to the compromised myocardial function, which are demonstrated in the pre-op assessment by signs and symptoms of decreased cardiac output and tissue perfusion. Measurement of weight is important in the preoperative heart patient, as this provides a baseline for postoperative assessment as well as the administration of drugs. Compromised right-sided myocardial function causes the accumulation or damming back of blood in the systemic venous system. The accumulation of fluid produces a gain in weight. 1 pint of accumulated fluid results in 1 pound of weight gain. Conversely, the congestion of this fluid in the abdominal organs may result in abdominal pain or anorexia. Thus, the preoperative patient may report weight loss despite the increase in retained body fluids. The pre-op heart patient may present with a low-grade fever. Increased sympathetic activity, a compensatory mechanism to compromise myocardial function, produces vasoconstriction, which may impede the loss of body heat and result in a low-grade fever.
Are you allergic to any medicines or anything?
No.
No allergies?
Sure not.
Okay. And what kind of problems have you been having, Mr. Johnson?
A little short of breath, and that's about the main thing.
Okay.
No pain.
Anxiety observed in the preoperative patient may be precipitated by feelings of pain or dyspnea, additional laboratory and other screening procedures, as well as the fear of death. These feelings should be dealt with in the preoperative phase, as the associated stress and release of catecholamines further increase the workload of the heart and may ultimately hinder recovery.
All right. Would you describe yourself as being anxious about your surgery tomorrow?
Yeah, I'm anxious about it. I want to get it over with. Apparently it needs to be done. And I have a lot of anxiety, but no qualms about it.
You have your mind made up, this is the way you want to go. Okay. All right. Okay, well, hopefully some of the education that we're going to give you will help alleviate some of the anxiety, but, you know, some of it is going to be still there, as you know.
Sure.
And I hope you're free to ask us whatever questions you need to as we go along, so that everything is clear for you, and that, you know, any confusion will be cleared up, and that might help alleviate some of the anxiety.
All right.
Okay?
Sure.
May I go ahead and take a blood pressure on you?
Yes,
listen to your heart and lungs? Okay, good.
Blood pressure is an essential component of the pre-op assessment. In the context of coronary artery disease, hypertension is defined as the elevation of either systolic or diastolic pressure. Elevated systolic pressure is more predictive of an increased risk. Levels of 160 millimeters hemoglobin are a definite concern. Elevated blood pressure is believed to cause damage to the endothelium of the coronary arteries and disrupts the antithrombogenic and permeability barrier. Recognizing preoperative hypertension in patients is valuable in the anticipation of postoperative hypertension, which can precipitate or exacerbate bleeding from the mediastinal chest tubes.
I'm going to listen to your lungs right now.
The preoperative heart patient may present with an increase in respiratory rate and effort, crackles, or diminished lung sounds. With the compromise of left-sided myocardial function, fluid may accumulate in the pulmonary circulatory system because of the outflow of oxygenated blood into the systemic arterial system from the left ventricle is decreased. This pooling in the lungs causes an alteration in the ventilation-perfusion ratio, resulting in impaired gas exchange and increased breathing effort. One of the body's normal compensatory mechanisms for hypoxia is to increase oxygen intake by increasing the respiratory rate. Unfortunately, the increased respiratory rate causes an increase in cardiac workload, further intensifying the hypoxic state. Retention of salt and water and increased vascular pressure further contribute to peripheral pulmonary edema by impairing gas transport from the alveoli to the blood, secondary to the increased distance for perfusion. Thus, crackles or diminished breath sounds may be heard. Additionally, the preoperative heart patient may describe orthopnea or shortness of breath when lying down. They may report sleeping in a recliner or propped up on 2 or more pillows to sleep. Gravitational forces that cause fluid to become sequestered in the lower extremities when the person is sitting or standing are not operational when the person is supine. Fluid is then mobilized and redistributed to an already compromised pulmonary circulation. Compensatory sympathetic activity may also produce tachycardia. Additionally, the patient's pulse may be affected by therapeutic medications taken for heart disease. Cardiac auscultation is performed to determine heart rate abnormalities and the evidence of atrial, ventricular, or summation gallops. The PMI, or point of maximal intensity, may be displaced to the left and downward, indicating dilatation. Peripheral pulses are palpated for evidence of decreased quality and abnormalities. Pulses are a direct reflection of the contractility of the myocardium as well as the filling pressures. Postoperative assessment of the peripheral pulses will be evaluated in comparison to the preoperative data. Patient pulses may decrease due to cardiovascular disease and the resulting loss of resilience in